The number 2 cause of death in the US and I believe worldwide and emerging, progressing towards number 1 is cancer. Cancer, yes. And the conventional approach to say it is a miserable failure is being profoundly understated. So wouldn't it be nice to have something better, a strategy that relies on upregulating the body systems and doing it in a way that is safe and non-toxic and relatively inexpensive? So along those lines, I'm interviewing one of the world's best and leading integrative oncologists. I think she is really beyond outstanding and so excited because she's written a new book, Mistletoe. So we're going to engage in that and even more so some of the philosophical strategies that one needs to have to address this more comprehensively. So you're going to love this dialogue.
One of our physicians has been using mistletoe for 45 years in his practice. And what we've seen clinically, what the research suggests, is that this therapy, it has always been about using it with others. It plays very well with others. It was never really developed to be a standalone therapy, though believe me, we've seen impact with that as well. And that it has virtually no contraindications with any of our standard of care therapies. So we can literally inject this into a patient the morning before they go into a surgery, or they can start on this therapy the very day they're going to start a round of chemotherapy or radiation. It bypasses first phase detox pathways of the liver, so it doesn't interact or intervene or speed up or slow down detox processes that could otherwise cause some adverse events or change the behavior of the desired effect of a certain medication or a certain herbal intervention or dietary intervention. And so it really does play well in the system with others. This should be utilized, in my personal opinion, with every patient going through a standard of care approach to just enhance their experience with treatment. There's a lot of things that we kind of have to be careful with, but mistletoe, in my experience and that of my colleagues, is that this is probably the least harmful and least contraindicated substance in therapy I've ever had the privilege of working with. It is pretty extraordinary and pretty rare to find something that is this applicable to the masses. As I said, it is, over 100 years old of continuous use. It has over 250 very good, randomized studies. It just completed a phase 1 clinical trial at Johns Hopkins in the United States as an IV application for solid tumors, and is getting ready to move into a phase 2 clinical trial. We think of mistletoe as the kissing plant. And if someone studied it in any framework, they'll see that it's been utilized in medicine for thousands and thousands of years.
Welcome, everyone. This is Dr. Mercola helping you take control of your health. And we are going to take a sidestep from our normal routine, which is discussing COVID-19. But interestingly, if you understand this topic, it will unequivocally give you the tools and the resources to help prevent any damage from any infection, including SARS-CoV-2. So the divergence we're going to emerge into today is the second, probably going to the leading cause of death overall, which is cancer. And we're going to talk about a fascinating component of it that I didn't realize until I got a copy of this book written by Dr. Nasha Winters, who we're going to be dialoguing with today. And the title of the book is Mistletoe and the Emerging Future of Integrative Oncology. So I don't know that many of you have heard of it. We're going to hear a lot about mistletoe today, and more importantly and broadly, the strategy one should take to hit this. I mean, this is, interestingly, well, we'll talk about this, but cancer is not a new disease. I mean, it is a new disease for the most part. It didn't essentially exist 150 years ago, but now it's like one of the leading and progressing to the leading cause of death. So you really have to understand how to approach it, because either you or someone you know or love deeply will struggle with this. Guaranteed 100%. And most of you watching this, it's already the case. So this is going to be a fascinating resource because Dr. Nasha Winters is, in my view, the leading go-to integrative oncologist in the US, maybe the world. I have enormous respect for her. I didn't always have that view of her. I was somewhat skeptical, but over the years, I've come to appreciate that about her. And there's no doubt if I ever come down with cancer, I doubt I ever will, but if I did, I'd see her first. And she kind of agreed to see me, which is really good, because she says it's impossible to see this woman. She's such in demand that the only way to get to her is indirectly through the people she's taught. So fascinating woman. So we are just privileged to be able to dialogue with her today. So with all that intro, welcome and thank you for joining us today.
Thanks, Doc. It's so good to be here. As I was saying to you before we got started, I think about you a lot. I know you have, you are being kind of the don't shoot the messenger guy. You've definitely been the messenger as of late and always have been. I mean, I've been following your work for many, many years. And I know with the type of things you say comes controversy, but our world is controversial times right now. And we have to be willing to lean into, the sort of out of the box concepts and conversations. And you have never shied away from that. So I'm really grateful for you.
Well, thank you for that. But it's not so much leaning into these concepts. It's just embracing the truth and helping people understand it in a way that gets them through the brainwashing. And thankfully, we've been able to really help a lot of people. And the reason they're focusing on me, it's not that my reach is so big. It's just that I have a powerful voice because I've been at this for a quarter of a century. When I say something, it's been my observation that many people listen because I know I have no hidden agenda, no ulterior motive. So that is why they perceive me as such a dangerous threat and why there's such an enormous amount of intense effort to discredit me and get me out of the picture. It's Christine, life is so great. The more they try to discredit me, the more important my voice becomes. It's just crazy the way they work. I think these guys didn't understand what they're doing.
You're like they're helping you market without you.
Yeah, you couldn't be better. So.
Well, it's interesting because controversy as well. Like I've had the same kind of dynamic. I've been, as of this month, October of 2021, at the time we're having our conversation, who knows when this will come, out to the public.
Post it, yeah. Sure.
Yeah. But at the time of our conversation, I'm coming on to 30 years out from a death sentence of a terminal cancer diagnosis and still to this day get met with so much resistance to what I've learned for myself and for thousands, if not tens of thousands of other patients directly, as well as maybe way more than that, indirectly through the training of their physicians. And so, I mean, talk about two of the most controversial things we can talk about today, which is oncology and sort of the immune system and its relationship to both a pandemic viral issue as well as a pandemic cancer issue. For me, they're the same source. It's a broken terrain. And that's where I put my focus. I don't put my focus on a virus and I don't put my focus on a cancer cell. I put my focus on the health of the host, of which those things will invariably land or meet us at some point in our existence. So that's my crazy controversy is that I focus more on the human organism and the health of that terrain versus the condition or the disease or the label that overlays that person or that condition.
And you picked a perfect profession to engage in, or at least develop your professional training. So, and I neglected to mention that, but thank you for laying the groundwork and frame for what encouraged and activated your interest in this area, a personal challenge. But then you went into naturopathic medical school because there's two different types of naturopaths. I had a girlfriend like 20 years ago who actually was a naturopathic physician like you. And I think you may even went to the same college.
I know her very well. Yeah.
Southwest College, probably about the same time.
Yeah.
And and it was her constant frustration. She's not practicing now. She's just a mother and that's a full-time job. But it was her frustration when she was that there was this massive confusion from the people, and not to disparage people who go to night school, but it's a totally different thing. And they don't have licenses like the 4-year schools. And there's only a few of them. So you went to one of those schools, specifically Southwest, I believe in Arizona. And, you acquired a set of skills that really helps you to understand the foundation of how to do it. And I appreciate you, laying that perspective that is the strategy. You're not treating cancer directly. You're upregulating, improving the body so it can respond to whatever it needs to adjust to and optimize the approach to defeat the challenge. So let's get back to mistletoe. Most of us know about it as that holiday decoration that you can swipe a kiss on it, and but it has far more profound uses. And prior to reading this book, I didn't understand, and would like your insights on this. It seems to me from reading your book that you have to be literally highly irrational and delusional not to integrate this into almost every therapy for any type of cancer. I mean, it's just crazy not to. So anyway, that's my summary, and you can take it off from there because this is your book.
What I love is that you're like, okay, we're done. We're good. You've got this. But no, this is really powerful. This therapy, just to kind of give a little context, as you said, we're kind of we think of mistletoe as the kissing plant. And if someone studied it, excuse me, in any framework, they'll see that it's been utilized in medicine for thousands and thousands of years. It has roots in Druidic times. It has roots in Hippocrates' time. It goes back, thousands of years as a significant herbal remedy for things such as epilepsy, for disorders of the spleen, as poultices and topicals for pain and rheumatic conditions. So it has been used as a therapeutic intervention, this semi-parasitic plant that you will see, growing in the branches of thousands of species of trees from all over the world. And yet about just over 100 years ago, in 1917, talk about another controversial character, Doc, Rudolf Steiner.
Yeah, historic luminary for sure.
Exactly. And like someone who just had this keen observational sense, which I think is very important to be a good practitioner today anyway, is to be a good observer of nature and the people and the interactions around you. And Rudolf Steiner, this philosopher, happened to look at the trees and notice this plant growing in them and said, boy, that it looks like a tumor. And as is the case for many vitalistic medical practices, from Ayurveda to Chinese medicine to naturopathy to homeopathy to even aspects of osteopathy and beyond, we see this concept of the doctrine of signatures. So for instance, you look at a walnut and it kind of looks like a brain. And we think, I wonder if that's any good for the brain. And sure enough, we find some significance in how it impacts the brain, or things like lungwort. When you look at it, it looks like a lung. And yet we've learned that this this herbal medicine is very helpful for lung conditions. Well, the similar thing was happening with mistletoe growing in these trees. And it wasn't applied for a few more years after he made that observation in 2017. It was a doctor in Switzerland, Dr. Ita Wegman, who started to apply his observations to the human condition to see how this medicine impacted a patient with cancer. And so it's since then, enjoyed over 100 years of consistent application in the field of cancer as both a standalone as well as an adjuvant support. And interestingly enough, who knows how in the world this man figured this out all those years ago, but in his observations, Rudolf Steiner understood that you needed to harvest different components of the plant. So the berries that bloom in the winter, which is very abnormal, and the leaves that grow in the summer, and that it never touches the ground, and that it grows inward, and that it has a very, interesting behavior compared to all the other plants. That was also an observation of sort of how cancer works as well. It goes against the rhythm. It grows out of sync with the organism. That is very much what he also recognized in this. And as such, he harvested the plant and aspects of the plant at different times, blended it, and then took a particular extract from it. And he also noted that it needed to be injected, because you have to remember 100 years ago, we didn't know about lectins. We didn't know about viscotoxins. And somehow he understood that you needed to inject it to get the cancer benefit, to get the anti-cancer benefit. Whereas today you could take the full tincture, you could take it in other ways, and it has a lot of other medicinal impacts, but it doesn't have the anti-cancer impacts. And the reason being, we've learned, or at least we suspect, because we're still learning, is that those lectins and things get broken down in our GI tract. And they don't get into the bloodstream, and they don't access the immune system in the way they need to when we inject it, either subcutaneously or intravenously, or even peritoneal or intrapleural, or even intratumoral, which is what we talk about in the book.
Yeah. So I definitely want to get into the mechanisms because it's pretty fascinating how it likely works. But can you respond to the question if you believe that, as I suggested earlier, that it's likely useful as an adjunct in any therapy for any cancer?
100%. And I've been training physicians on how to use this for several years now. And now I'm with a group. In fact, the co-authors of this book, we all actually run a course now. And you'll notice in our group of physicians, we are naturopathic doctors, we are medical doctors, we have one DO in the mix, and one of our doctors is even a hematological oncologist at one of the largest hospitals in Europe, specific to cancer. And so with that being said, these are legitimate, we're a collective coming together with decades and decades of experience. One of our physicians has been using mistletoe for 45 years in his practice. And what we've seen clinically, what the research suggests, is that this therapy, it has always been about using it with others. It plays very well with others. It was never really developed to be a standalone therapy, though believe me, we've seen impact with that as well. And that it has virtually no contraindications with any of our standard of care therapies. So we can literally inject this into a patient the morning before they go into a surgery, or they can start on this therapy the very day they're going to start a round of chemotherapy or radiation. It bypasses first phase detox pathways of the liver, so it doesn't interact or intervene or speed up or slow down detox processes that could otherwise cause some adverse events or change the behavior of the desired effect of a certain medication or a certain herbal intervention or dietary intervention. And so it really does play well in the system with others. And it has, as we'll talk about here in a bit, some mechanism of action, which is very, very interesting. But what we find most interesting is that it enhances these therapeutic interventions, even the most toxic of therapeutic interventions, and seemingly brings a better quality of life and a lower side effect profile to the patient. That, as you said earlier, this should be utilized, in my personal opinion, with every patient going through a standard of care approach to just enhance their experience with treatment.
Yeah. So interesting that it has no contraindications. That's very unusual and odd in medical therapies, including, one of the things that clued me into your initial my initial fascination with your approach is that you widely embrace the use of cyclical ketogenesis and the metabolic approach to care therapy based on Tom Seyfried's work. And interestingly, with that approach, there are some contraindications, and especially with cancer. I mean, if you're cachectic, you're playing with major danger if you start that type of intervention. So, this is even more broadly applicable than cyclical ketogenesis.
I have to agree with that. I mean, that's where I love it is that you can really pair this very well with standard of care therapies, with dietary interventions, with herbal interventions, with physical treatment interventions that are often, that a ketogenic diet can actually, be contraindicated in some of those situations or certain different times, or that certain herbal remedies are contraindicated with certain, like everyone gets excited about green tea or gets excited about curcumin and makes it sort of a panacea. And yet we know that high dose curcumin or even green tea extract can actually cause liver enzyme problems and impact the liver pathways. We also know that green tea extracts for some people with certain epigenetic expressions with like a slow catecholamine COMT SNP is actually contraindicated and can actually make someone's estrogen back up more in the body and cause problems. So there's a lot of things that we kind of have to be careful with saying, hey, it's good for everybody. But mistletoe, in my experience and that of my colleagues, is that this is probably the least harmful and least contraindicated substance in therapy I've ever had the privilege of working with. And I'm still learning from this plant, as are my colleagues, and the research is learning along with us. So to your point, it is pretty extraordinary and pretty rare to find something that is this applicable to the masses.
Yeah, and I think not only is it the least dangerous, but it's probably the least appreciated or at least well known, because I really wasn't aware of it, and I'm pretty astute to understanding that these things early on. but it never really impressed me before as being something that's so crucial and important to integrate into every approach for cancer. And believe me, I've a lot of friends that I've known through the years have had it, and I would never recommend it, but now it's definitely part of the strategy. So would you say that's true also, that most even natural medical physicians aren't aware of how
Absolutely.
helpful it is?
Absolutely. And in fact, when I started training physicians in this several years ago, I had a lot of pushback. And ironically, the biggest pushback I had were from the naturopathic community. They were terrified of using this therapy that was quote unquote unproven. And I'm like, you have to understand, just because it hasn't been FDA approved does not mean it is not an effective medication. Just because we are not extremely familiar with it in the United States does not mean it is not well understood and utilized abroad. And just because it may not, be something you were taught in medical school, be it naturopathic or osteopathic or conventional medical training, does not mean it is not a powerful therapy. As I said, it is, over 100 years old of continuous use. It has over 250 very good, randomized studies that would be even considered excellent studies within standard of care in the United States today. It just completed a phase 1 clinical trial at Johns Hopkins in the United States as an IV application for solid tumors, and is getting ready to move into a phase 2 clinical trial. It is the most studied integrative oncology therapy in the world, and it is utilized in upwards of 60 to 80% of all cancer patients in Europe will likely utilize this therapy at some time. And it's even in the sort of repertory or the registration in parts of South and Central America, all over Southeast Asia, in India, in particular, different parts of Europe. This is just part of their medical system. And our colleagues just north of the border in Canada have it registered, and our folks south of the border have it registered. It's just in the United States where we have a little bit of resistance to and sort of embracing it into our conventional medical system.
Yeah, and with this last 2 years of the COVID nonsense, it's easy to understand why. I mean, it couldn't be more flagrant and flagrantly obvious. It's the reason is it's the drug companies. They love to suppress things. I mean, we have well-documented drugs even they like to suppress because they're competitors, hydroxychloroquine and ivermectin. I'm not huge fans of them. They clearly work. I think there's better strategies, but clearly I have no objection to anyone using them as certainly as an alternative to what they're recommending, the COVID jab. But it's the same process, and it's so blatantly obvious that they do this. And so it's just easy to understand that they're doing the same thing for anything that's threatening their financial revenues in oncology, and they're significant. If I'm not mistaken, and you can support this, I remember this from earlier interviews with talking to some oncologists, that I think oncology is the only specialty in medicine, the only one where they sell the drugs directly to the patient. And these drugs, as most everyone knows, are expensive. Maybe give us a range, and I think it's maybe $100,000 a month or even more in some cases. But I think the clinician gets like a significant cut, maybe a third or half of that.
Well, and it's interesting because there's elements of truth to that. I can't speak to exactly what it is, but I do have a handful of colleagues that are standard of care, conventionally trained oncologists who would verify what you're saying just from their own clinical experience, and have decided to sort of step out of that because of conflict of interest, and also because they don't want to be limited in utilizing therapies that actually can enhance what they do. Right. And help their patients have better outcomes and make their outcomes look better, at the end of the day. And so, a little thing I want to go back to, because you talked about this, about kind of the drug suppression or therapeutic suppression from the system. I mean, as a naturopathic physician who's been practicing integrative oncology for some time, and who has teachers, mentors, colleagues, friends from all over the world, some of the most powerful therapies I've seen as anti-cancer that are beneficial even to the standard of care model of treatment, things like artesunate, curcumin, quercetin, a green tea extract, all of those in intravenous forms. Those have been taken out of our ability to use here sort of outwardly in the United States. Do my colleagues still find workarounds on how to get access to these very important medicines? Absolutely, they do, but they have to tread very, very carefully and very lightly. But again, you go north of the border or south of the border, and you have no problem accessing these therapies. Or you go to Europe, and this is what I've been doing for the last 2 years, is these treatments that we've had great success with have been plucked out of our ability to access easily, readily, legally. We're now having to send our patients abroad for them to actually get good cancer care. That's what's really devastating to me. And another part of my purpose and mission is to build a research, an in-house residential research institute and integrative cancer hospital right here on our soil, so we don't lose access and patients don't.
Do you think that's possible in the U.S.?
Yeah.
I mean,
well, it is.
it just seems so unlikely with things are getting worse every week.
Yeah.
They're abandoning, every semblance of rule of law and the tyranny and, the lack of effectiveness of the judicial branch of the government. I mean, it just doesn't hardly exist anymore. So they're just destroying freedom and personal liberties. So how could you get away with doing that type of research in the U.S.?
Well, first of all, we're completely out of the model. So we are not going to take insurance, and the hospital is a not-for-profit hospital. So it will be cash funded. It will be research grant funded. It'll be philanthropically funded, and it will be endowment funded.
Don't you think they'll shut you down? I mean, look what they're doing.
They'll try. But the beautiful thing is we have thousands and thousands and thousands of patients that have been waiting for the doors of this to open. The other thing is we're a research institute. So we're getting ourselves really dialed in that we will be doing all of our due diligence to let people know that these are not FDA approved therapies, that people are coming in a research environment. They're either paying cash or they're getting, grants, based on their financial ability to help them cover this care. We're doing it in a pretty open-minded medical state. The state of Arizona has one of the broadest scopes of practice in the country. And we're also very close to our southern border again with Mexico, so that if we do come up against someone shutting down one of our therapies for a bit, we are able to take our patients across the border to a little sister clinic to keep the continuity of care. We don't anticipate that happening because people are coming as a buyer beware. They're coming with being well informed to know exactly who we are and what we're about. And frankly, as you and I talked before the recording started today, we get thousands of inquiries a month from all over the world looking for this approach. The patients will drive this home. And I do have colleagues like you and others saying, wow, why don't you just do it in Mexico? Or why don't you just do it in Germany? Well, those places already exist to some degree. The biggest challenge is I want this to be on our soil. I want to leave a legacy of changing the care of cancer in this country. This is where it's about. And it's a mighty David Goliath story, if you ever heard one, especially now. But I also think the time is now, because we also have these acts like the Right to Try Act has passed. And because we do have more and more patients facing this diagnosis with grim outcomes. And because even a study that came out in the last year that looked at 17 years worth of conventional cancer treatments, the overall of 96 different drugs they looked at that were used over the last 17 years, the overall average survival rate of those pharmaceuticals was 2.4 months. Okay. That is the reality. And this is what's driving the clinical oncologists from around the world to sign up and take my course, right? And so I have physicians coming in from naturopathic doctors, integrative, functional medicine physicians, naturopathic physicians, functional medicine physicians, integrative oncologists, and standard of care oncologists, realizing that none of us are getting away from treating cancer patients, and that all of us need to do a lot more to support these patients. So there is this massive kind of underground movement that's starting to sprout and come above ground that's happening. And frankly, Mistletoe is one of the vehicles for that to happen. So I tie this back around because there was a big shift that happened when Hopkins took this on. And the irony is the only reason this clinical trial took place was not because NIH or some powers that be funded this study. This study was funded philanthropically and with people's donations and passion and purpose. That is how we're getting good research today. Non-industry driven, non-bias driven research to say, does this work? And we fully expected that they would do everything they could to shut down this trial. And it's been so effective that it's been approved to continue on into the other phases. We are very excited and hopeful that the tide is turning and that we have more and more people saying we'll philanthropically fund the research that's needed to show therapies such as mistletoe or some of these other off-label uses in certain viral patterns or other cancerous processes that can be happening under our roof. And so we're very excited about that possibility. And we are finding people coming out of the woodwork who are interested in helping fund this vision to come into reality in this country.
Yeah, that's really the only practical alternative, because Fauci has pioneered the process of really directing all this funding from the federal government, primarily through NIH, but of course he said the NIAID, and has directed over $1 trillion of funding from the federal government in this last 50 years in office, not in office, in his position at NIAID. So he's basically controlled it. I mean, all the funding goes to the principal investigators that are totally connected with pharma. And it's just this vicious cycle that is very difficult to penetrate. So really the only other way is philanthropic approach. So congratulations for that approach, because nothing else is going to work.
And that's just it. We had, instead of trying to fix the model, we're just creating a new one. I mean, really, this is about
sidestepping it.
Exactly. And similarly, like kind of coming full back around with mistletoe, where a lot of people, have been kind of against it, is you can't patent this. It's a natural therapy, right? And so that's where there wasn't interest. There was no big pharma interest of the money they could bring in. However, what we're also hoping to show is that it could lower hospitalizations. It could lower delay in treatment. It could lower side effects, that require medical intervention, that ultimately lower the bottom line of insurance coverage for patients going through standard of care. So we also know that back doorway speaks to the insurance companies and speaks to folks that may support this type of care for their patients. So what we're trying to do is build the bridge, because we know we can't go against it on one level. So we're building a new model, but we're also trying to build a bridge. And we're able to show that this therapeutic intervention, which when you look at the bottom line, a lot of integrative cancer therapies, Doc, are very, very expensive, very expensive. This therapy in comparison is one of the least expensive and most effective out there. You're looking at about maximum $250 to $300 a month of an intervention that, when you're looking at the cost of, say, vitamin C that's been really well, shown, or DCA, or some of these other, metabolic interventions, hyperthermia, we're talking thousands and thousands of dollars.
Tens of thousands sometimes.
Right. And so we're excited to have a therapy that basically is accessible, to the general population, and even different foundations and organizations exist to even help patients without the means get scholarships to purchase this product and to use it as a supportive intervention. So what we're realizing is, instead of putting our energy into funneling and fighting the old, we're very interested in just putting our energy into creating the new. And that's where I feel like in this, especially in these last couple of years, I don't have the bandwidth to keep fighting the old. So I'm just sort of like, I know there are lots of people like yourself and others out there who are taking on that. While you guys are kind of keeping them distracted with that, we're off building something entirely new in the healthcare model.
We're not fighting them. We're just exposing. We're exposing them.
You're exposing.
Because they are so sophisticated and powerful that it's almost impossible to fight them. Unless you do some very clever strategies like in the art of war, but you can't fight them directly. They're just too big. So let's get back to mistletoe, though, because you mentioned in one of these expensive interventions, hypertherapy, one of them, pretty effective, but that's probably, it can be used like that because it actually raises your core body temperature if used intravenously. And there's a whole variety of methods that one has to understand before you can apply it, because there's different species and you have to understand those to use it. But why don't you discuss that, and then some of the other mechanisms? I think we've laid the groundwork that people can understand. There's a high likelihood it's going to be useful, but it helps if you understand why it's useful.
Yeah. Well, one of the things we've been doing, when I was starting out in practice, I knew that the immune system was integral to how we were going to deal with cancer. Right. I knew it was a very big important, the metabolic and the immune function. First of all, they're also very tied together, which we're finding. We're seeing that our bodies are unable to fight a basic virus if we're metabolically broken. right? So we can't separate those out into a silo either. This also applies to how mistletoe works. So if someone's still living on a standard American diet and still metabolically broken, mistletoe is going to be less effective for that person than someone who's also taking charge of their health in other ways. So I do want to paint that picture as well, that it's not the magic bullet and isn't the magic fix.
Mm-hmm.
What it is, however, is an immunomodulator. We do know that. And in today, where we're funneling billions of dollars into clinical research on immune therapies, that just a few years ago, these same oncologists that are super excited about immune therapies, just a few years ago, poo-pooed the idea of somebody like me saying that it's important to get your immune system functioning to deal with cancer, right? So until there was a drug that they made money from, this just sort of didn't exist. It's, it's just the way it is. But the thing about today's modern immune therapies, which are where we're funneling the majority of our research dollars now, is that they are less than 20% effective. And by effective, I mean response rate. And by response rate, I mean to be able to look at a scan or an imaging, or to be able to look at a tumor marker and make a difference, bring it down a little bit. That does not mean cure at all, right? But the languaging we put out there in advertising the success of these therapies makes it sound like they are cures. So to be, just to reiterate, only less than 20% have a response to these blockbuster immune drugs.
Yeah, could you just give an example of some of them? Because I know you're very familiar with them, and it's likely many people would be also.
So a lot of folks have heard kind of like Jimmy Carter's story, with his brain, his melanoma that had messed to his brain, and that he took this immune drug and is now really kicking. Well, that drug was Keytruda. And so that's a checkpoint inhibitor. And that is basically the most common drugs you'll hear about are things like Opdivo, Keytruda. You might hear about PD-1, PD-L1 inhibitors. Those are checkpoint inhibitors. Or CTLA4 inhibitors, also a type of checkpoint inhibitor. These are drugs that block kind of pull the brakes off your immune system to go hog wild in treating the cancer. Now, that seems like a great idea unless you have underlying metabolic dysfunction, right? Hello?
Which 90% of the population has.
Yeah, 88% per studies. But
well, that was 2016 data, so I'm sure it's over 90.
100, I totally agree. And then also the amount of autoimmunity. If you have an underlying autoimmune condition, you are also someone who's likely going to have a not so positive response to these medications. What I love about mistletoe is it comes in and it modulates that teeter-totter. It doesn't take the brakes off and make it go hog wild, and it doesn't suppress. It basically says, hey, are you overexpressing in this direction or this direction? And it modulates, thinking kind of adaptogenic in some ways. So it behaves a little bit like a smart bomb, a smart drug, in that it can kind of sort of match itself to the individual. It is not a protocol. It's a patient-driven process, and that to you mentioning this earlier, we look at the person's gender, we look at the tumor type, we look at the tumor stage, we look at the general condition of the patient itself. And then we consider the most appropriate host tree. The most common are the pine, the fir, and the apple tree hosts for mistletoe tend to have the highest lectin content, that have the highest anti-cancer content. And then we look at the dosing frequency, and even if we're going to do it subcutaneous, intravenous, intratumoral, intraperitoneal, et cetera, depending on where you live in the world, and how we're going to pair it with other therapies, if at all, right? So it is based totally on the individual and the individual's response. We want the patient to have a little local reaction if they're injecting it. We want it to get a little redness and irritation and itchiness and maybe tenderness. We want it to raise the body's temperature a little bit. IV therapy will do that even a little bit more robustly, intratumoral even more robustly. And so the point is we want to create this cytokine release at a very low grade level. Whereas when we bring on an immune drug like Keytruda, it creates a cytokine release at an explosive level that can sometimes be fatal for patients.
I assume it's not targeted also, it's systemic.
Exactly. And that's just it, is that we're not looking for a single receptor site like those drugs are looking for, right? So they're looking for a PD-1 or a CTLA4 receptor site. This is a systemic terrain-centric approach. And so in its mechanism of action, It's engaging with the B cells. It's engaging with the T cells. It's engaging with natural killer cells. It's basically saying, hey, are you guys online or offline? If they're overzealously online, it calms that down so you don't get this massive immune reaction that can be problematic. And if it's dormant and not behaving properly, it wakes it up. It stimulates it to do its job as it was meant to be. It also has this very uncanny ability to lower inflammation directly. So we can even do testing. Like, I love to do testing. So we can watch C-reactive protein, interleukin 6, homocysteine, LDH, liver enzymes. We can watch those things come down with this so we can see it in real time. So we're not just guessing. We can see that it's having an impact on the immune system by a good old CBC, because we'll see the eosinophils come up a little bit. We'll see kind of a normalization of our neutrophil to lymphocyte ratio, which you and I've talked about in the past, and the importance of that. We'll definitely see that piece. We can also measure serum or plasma VEGF, vasoendothelial growth factor, which is a driver of angiogenesis.
I didn't know you could measure it. Is that a commercially available test?
Yeah, you can go to LabCorp or Quest. You can get.
Wow, I did not know that was available.
Yeah.
Are there any nuances in measuring that? Like, does it have to be fasting or?
I always tell my patients fasting just to, I'm usually doing a pile of labs. So we just do that. But I definitely use that as a baseline, especially if someone's wanting to put them on an angiogenic inhibitor. It's like, well, let's see, because we can test that in the tissue and on a liquid blood biopsy to see if the tumor or the tumor cell expresses VEGF. But we can also see what's happening systemically with VEGF, and we can mitigate that.
Yeah,
watch that come down.
VEGF in cancer is the nightmare. You definitely want to suppress. There's a lot of drugs targeted toward it, but actually, if you're trying to get healthy, it is absolutely crucial. And if you don't activate the production of VEGF, you'll be absolutely guaranteed to develop frailty.
Well, and that's what happens. A lot of these folks get on these drugs, the anti-angiogenic drugs, and they end up basically jumping from one frying pan into another.
Yeah.
And what we see, what's very interesting about the anti-angiogenic drugs, things like, as an example of that, is Avastin. If a patient's on Avastin, typically within 3 to 6 months, I start to actually see their serum or their plasma VEGF start to rise. I start to see other angiogenic processes happen, such as copper angiogenesis will start to rise, because, as you said, we need vasoendothelial growth factor just to survive. Right. Yeah. And so the body is going to find a workaround. So if you're blocking it, if it's your whack-a-mole blocking it over here, it's going to find another way to overactivate. But if you've not modulated and changed the terrain, you can actually create more angiogenesis that feeds the tumor versus the terrain when you're on those drugs that block. And so, like, an interesting thing, vasoendothelial growth factor activation, the number one there's two major causes of it. Metabolic dysfunction. So basically insulin drives it, as well as stress response. So cortisol drives it. Those are the two biggest things we deal with on our planet today. And so you can put all the Avastin you want in the system to block that pathway. But if you don't also address the stress response and the metabolic response and clean up the terrain, it's going to find a workaround, and it's going to be just as aggressively activating of that tumor growth as anything else. And so I love that you have this therapy, Mistletoe, that comes in that lowers inflammation, that lowers VEGF, that actually one of its most potent and most studied interventions or mechanisms of action is that it's a quality of life enhancer, right? Specifically what we believe.
So important.
We think that it's upregulating both the endorphin as well as the endocannabinoid system. It seemingly has.
This is all from mistletoe.
It is all from mistletoe. So then you're getting that stress modulation. And if you're getting that stress modulation, you tend to not be, using food as your drug of choice. Maybe you have a little more wherewithal to choose better, options for yourself versus medicating, with sugar or alcohol. And then, interesting, we've actually had several studies that it does, in fact, lower blood sugar and lower insulin. So it really is hitting all of what we call the terrain 10 from my previous book, The Metabolic Approach to Cancer. I find that mistletoe tends to hit every one of those drops in the bucket, from epigenetic expression. We use it to clean up DNA. So we use it for people who've gone through radiation. We'll use it as a DNA stabilizer. We'll use it if people have taken a course of Cipro to help clean up the metabolic mayhem, the DNA damage that Cipro causes to the system. We know that it has some impact on insulin in IGF-1. We know
I'm assuming that would be for all fluoroquinolones, not just Cipro. Too.
Thank you. Exactly. All the fluoroquinolones, all of them. So it definitely has impact of supporting that. And in our book, we have hundreds and hundreds of references to all of the different mechanisms of action. And there's a couple really great, like my colleague, Dr. Paul Faust, he does a beautiful chapter on its direct impact on the immune system and all the nuances of that, which is, boy, howdy, that is really the hot topic today, both in COVID, but also in cancer and cancer research. And that chapter alone will illuminate for so many people why this therapeutic support and this therapeutic intervention is so helpful for the cancer patient, for prevention of cancer, for cleanup after cancer treatment, and also for other conditions. So we see very good benefit with it in modulating autoimmunity and having some antiviral effects. It's being used in the Lyme community. Which is I tell people all the time, I think it's easier to treat cancer than Lyme, or work with people dealing with cancer than Lyme. It's such a tenacious systemic condition. We're finding that mistletoe seems to have very beautiful impact there.
And interestingly, hyperthermia is an intervention that's sometimes used to treat Lyme. And Absolutely. So the mechanism of action may be pretty similar from that perspective.
Totally. And when you put them together, the synergy, when you pair mistletoe with hyperthermia, like so many of my colleagues in Europe have been doing for the past 50 years, talk about the biggest bang for your buck. We see some pretty extraordinary outcomes where I've had patients go over to Europe, stage 4, sent home to hospice, unbelievable metastatic disease everywhere, getting IV mistletoe along with both local, regional, and whole body high heat hyperthermia that have put their cancer into complete remission. In many cases, but at the very least, into turning it back into a manageable disease process. And even more interesting, increasing the responsivity to other therapies again. So basically, when patients become resistant, using a fever therapy like mistletoe by itself, or like hyperthermia, or a combination of the two, you actually can make that patient start to respond to their previous pharmaceutical interventions again. So overcoming that drug resistance. These are the places where I try to encourage my standard of care naysaying colleagues that we actually make them look better. Like this therapy is actually helpful to make their therapeutic interventions work a bit better. And so that's where you and I kind of started this conversation today, is why is this not available to everyone, to help the, enhance standard of care, but also protect and support the terrain that surrounds those tumors and those tumor cells.
Yeah, let me just summarize and help you clarify. The most effective form of mistletoe intervention, especially if you're treating aggressive cancer, would be intravenous. And this is not something you want to do by yourself. You really need a clinician who can guide you through the process, because, you provide supportive training for a group, and I definitely want you to discuss how people would find access to someone who understands how to use this therapy. And again, reinforcing the point that this is not an expensive therapy.
Right.
The cost of the therapy is going to be somewhere between $200 and $300 a month. Highly affordable, highly effective. I think it's beyond irrational not to integrate this into any cancer therapy you're considering.
Exactly. And I do want to come back to the point, from 2003 until 2014, I only used this therapy as a subcutaneous therapy, because that's the only thing I'd learned. And that's the only way I had known how to apply it. And it was the only way I had access to it. And it in some ways, I'll be very frank, I think it put me on the map as an integrative oncology expert, is because of the patient experiences that then shared their experiences on forums such as Inspire, these cancer forums online, where people started describing that, they were terminal, they were stage 4, they were having terrible side effects, their conventional treatment stopped working. And suddenly they started working with somebody like me with this subcutaneous intervention that was a game changer for them on everywhere from putting them into complete remission to enhancing their quality of life, to taking away their pain, to making their standard of care drug work better, to building up their bone marrow so they didn't have to skip so many treatments because their bone marrow was too low to get the next infusion of chemotherapy. You name it, it started to bring that to awareness. And I did not start using the IV form of it until 2014, when I had a patient who, we talk about this in the beginning of the book, who was going home to basically say goodbye to her family in Europe. And she was in incredible pain. She had clear cell carcinoma of the uterus that had metastasized everywhere. This is a very aggressive cancer that does not respond to standard of care interventions. And she'd, quote unquote, been failed by, although the wording they usually use is failed, that she failed the treatment, but she was failed by 3 different lines of standard of care therapy. So she basically went home to say goodbye. And in the interim, we thought, well, we could do some pain intervention and quality of life intervention with a colleague of mine who's doing high dose, IV mistletoe along with hyperthermia. She did 2 weeks in his clinic. She came back a month later, had a scan, and more than 80% of her disease burden was gone. Mm-hmm. And yet her clinicians at a big, well-known cancer clinic said to her, well, you'll still be dead in a few months. And so instead of them celebrating the news, they basically still, went to the same beat of the drum saying, you're going to be dead very soon. And she was pretty devastated by that. And I said, well, why don't you call the doctor who treated you in Germany and see what he says? And he basically was like, oh, well, it's kind of disappointing that there's still a little residual. Why don't you keep working on your train and come back in 3 months and we'll do one more round of therapy. This woman was given less than 6 months to live. That was in 2014. She's still here completely free of disease today with that combination. And it was from that encouraged me to step out of my comfort zone and bring access to mistletoe intravenously into my clinical practice. And it was then a few months after that I was contacted by Johns Hopkins saying, we've been watching you. You haven't killed anyone with this therapy yet. Mm-hmm. And we are trying to start a clinical trial. Their initial clinical trial for mistletoe in this country was going to be subcutaneous for stage 4 pancreatic patients only who had, quote unquote, failed previous lines of therapy. When they attended the same conference I attended in September of 2014. They heard the case study about my patient and they got curious and then realized no one was doing this really in the United States. So when they started apparently stalking me and realizing I was doing it and having really interesting outcomes, that's when I went back and helped them design a different IRB and a different study design to do an IV clinical trial on all solid tumor types that had been basically left without any other option. So it's still just the nature of it, the beast. It was still for folks who were failed by standard of care, who had solid tumor, who were otherwise, no other options.
And what's the status of that Hopkins trial?
Phase 1 is done. Phase 1 is done and they're doing, we're moving into phase 2 and all the data from phase 1 is being churned for publication. So we know it was favorable. That's about all I can say without breaking all the rules and regulations, but enough that the FDA has already approved a phase 2 and 3 trial. So now they're philanthropically gathering funding again to pay for that phase 2 because we've talked about already, no one's interested in standard of care to fund this trial, yet it's clinically relevant enough that it's creating the curiosity to keep going and studying. So that's how these things have kind of impressed upon me that this is a therapeutic intervention that, this was a gal who was really in trouble and I still had great success with sub-Q for many years. But when IV came under our ability to use, we could really hit some very, very aggressive cases that help stabilize and turn things around enough that helped the patient actually get their feet underneath them so they could start to change their diet and their lifestyle and bring on other interventions to help shore them up. Because the first time I used it in office was with a woman who was in hospice, who was basically incoherent and in extreme pain that even morphine wasn't touching it. And so we took the IV to her home, expecting to give her end of life care. And that was, my gosh, 7 years ago. And we thought she had days left. And I was called in by my local hospice team to help give her, because they've worked with me before, brought me in doing acupuncture and homeopathy and other therapies, and seen that we could bring some good resolve and good support for people in end of life care. So we brought that in as an intervention for end of life care. And she's still here to tell the tale. So, that was not anyone's expectation. And I don't mean to imply that that's what everyone's experience will be, but it was enough that made me feel bold enough to say, holy cow, if I can do this, what else can I do? And so that's where I started training physicians all over. And my colleagues and I now train with the Physicians Association of Anthroposophic Medicine, also known as PAM. They're who sort of sponsor these trainings. We now have one available online for physicians. And then we will be doing a live event. We're actually taking physicians next fall, 2022, to Europe to go into the hospital environment to actually see real times where you're doing boluses of mistletoe into pancreatic tumors or into the portal vein for people who have, HCC, the hepatic cancers that are very, very aggressive. There's a consideration of a clinical trial at one of the big institutions in this country specific to that cancer type because it doesn't fare well per standard of care.
When they inject the tumors, is it under ultrasound guidance?
It is.
Yeah.
Yep, it is. And in some of the cases where we've seen at some of the presentations, live CT guided embolization of mistletoe into the portal vein or into tumors into the pancreas, I've seen some pretty extraordinary experiences with that. And so we're taking physicians who have that capability, who work in environments that have CT or ultrasound guided imaging to be able to learn and master how to bring those in. We'll be definitely offering that in the hospital in a clinical trial setting in the not so distant future once we can get that hospital up and running. But that's where colleagues are doing this abroad successfully and writing papers about it.
So I am certain that many people watching this would be interested in finding out how they could avail themselves to a clinician who is trained in properly administering this therapy. So how would someone find one of those clinicians?
Sure. So first and foremost, I'd go to the PAM website, which is, I believe it's wildapricot.org. Your search engine would take you to www. I want to make sure I'm getting this correct here. The place that's going to get you the most information on even the research and resource, as well as where to get training, is anthro, ANTHRO med.org. /mistletoe. That's also the repository for articles, as well as research, as well as who to see for clinicians.
Perfect.
And then the clinicaltrials.gov has the Johns Hopkins information of what's been completed and what's getting ready to start back up. And then there's a great mistletoe resource for ongoing literature and the evidence that's out there outside of the United States, which is a European resource, which is mistletoe-therapy.org. and then /scientific literature. And we'll get you some of these links for your show notes here for folks to go on directly. And then folks like mtiofhealth.org, mtiofhealth.org, which is the not-for-profit association that I'm associated with, which is where we're building the hospital. We also offer grants to help patients access this type of therapy. So that's one resource. Plus it also resources out physicians that have been trained in this. And then another resource that is who funded the clinical trial at Hopkins, whose not-for-profit foundation funded the clinical trial, is believebig.org. All of those places resource out information about mistletoe, where to find a practitioner who is properly trained in it, as well as access some of the grants that are available to help people with funding issues have access to this therapeutic intervention. So again, we are in the workaround here. This is completely out of the system. And by design, that's why we think we'll be successful in changing integrative oncology in this country.
Are there clinicians in most areas, most big states?
I would say all the states have somebody, but they're definitely far and few between. But many physicians even can train patients how to do the sub-Q and telemed and get them access to it. So don't let that deter you.
Yeah, so don't get discouraged if there's not a local clinician. You can probably, if you have your physician, personal physician is interested in this, he can easily access the training.
Exactly. And we
have, he or she, sorry. They will be non-binary, but we can definitely access this now. Pam has our 3-day intensive training on this available online.
We are also launching a beginner's course in this online this fall 2021. And then we have the immersion advanced training in Europe in fall of 2022 on the horizon. And so I really encourage people, this is not a protocol. This is not something like once you pick up the book and read it, you're not going to be an expert at mistletoe, either giving it to yourself as a patient or being an expert as a clinician, though we give a lot of great.
Yeah, there's a lot. It's a solid book. You'll know if you really read it and understand it, you'll probably know as much as most of the clinicians do.
100%.
Yeah, it's a good, well written. I appreciate it.
Thank you. Well, we're excited. We're excited to help it be another part of everyone's toolbox in their plight with cancer.
Yeah, that was a great summary. And if you have any interest in this, when does the book go on sale?
So it is pre-order now. You can find it on drnasha.com to do a pre-order. You can go to the PAM site, that anthroposophical medical site. You can go to mistletoebook.com. That will also take you right to the pre-order link. Steiner Books is our publisher and will soon be available on Amazon. The book is available pre-order, and we are expecting it to come out into hardback print the first week of November. So we're about a month out from its launch to the rest of the world. Okay,
good. So we'll probably have this interview air the last week of October.
Perfect.
So that's good. Yeah, to help support the launch of your book, because it really is an important step in a very, very common, unfortunately pervasive clinical condition. So, so thanks for summarizing that. I also had a few curiosity questions, as long as I have you, because if you're interested in metabolic therapies, I'm curious as to integration of this. And I mentioned earlier that there are some contraindications, anorexia, but being underweight, which is very cancer cachexia is so common. So I'm wondering what your thoughts are on using ketone esters, which are expensive, but as costs go, it's still pretty low. Compared to other interventions, but will give you ostensibly give you similar benefits of actually doing it nutritionally. Yeah. So it seems to me like they're useful if you're going to target specific interventions like CT scans or radiation therapy. That it's you got to be out of your mind not to use those things, and it's sad that most people understand that. But I'm wondering if is it not only useful in that intervention, but also beyond, where you use it supportively as an ongoing therapy.
First, I love this. And interesting, you talked about earlier, cachexia may be contraindicated for ketosis. I actually have a very different experience.
Okay, unless you have an expert like you.
Exactly. You know how to get,
If you know someone to walk through the minefields, you can do it. But generally, the answer is no.
Yeah, agreed. And that's exactly, if you have a guide to walk you through the minefield, that is a perfect statement. We know how to help people use ketosis therapeutically to get them through cachexia. And one of those strategies, to your point, is ketone esters. I appreciate the esters over the salts for a variety of reasons. I think they're more potent and more effective. And to your point as well, we will use them therapeutically. So for instance, 20, 30 minutes before hopping into hyperthermia, hyperbaric oxygen, radiation treatment, we put it in.
Do you use it before or after?
Before. Yeah.
Okay.
And it's incredible because it puts that extra pressure in the system, which then creates an even more therapeutic response while protecting for things like the high cytotoxic therapies like radiation, or even hyperbaric can be quite cytotoxic, and hyperthermia can be quite cytotoxic. Wow. We can actually support that sort of storm.
And what's the dose range? How many grams do you use?
Golly, I somewhere between, some patients, it depends if they're already in ketosis.
Yeah.
I'd only need 5 to 10.
Okay, that's what I was thinking.
Yeah. If they're sort of ketosis naive and they're new to this, we might need 30 to 50. Like we might have to go a lot harder, but it is a very powerful tool to enhance the efficacy of some standard of care therapies, as well as some really well vetted integrative cancer therapies. And also if I have patients that are preparing for a PET scan or something, or patients who are starting to become work on creating metabolic flexibility, who are up against that carb flu, low carb flu, or really struggling to get their ketones up. we'll use that to kind of help push them up over the hurdle. It can really put people there and really help people even clean up, like after they've done a round of, say, steroids, for instance. Maybe they've just had a brain surgery for their glioblastoma. We'll use the ketone esters to get them into therapeutic ketosis as quickly as possible to clean up and scavenge up all of the damaging effects and the growth factor effects of that hyperinsulinemia that comes with the steroid.
Yeah, it's such a powerful, relatively inexpensive, extraordinarily safe, and virtually unknown therapeutic intervention.
Agreed. Totally.
Yeah,
agreed.
it's just probably a little bit more than mistletoe, but not much.
Well, and to do them together, like if I have a patient who's getting ready to do hyperthermia or radiation, to bring that sort of trifecta together of, the intermittent fasting with a little ketone ester bolus with your mistletoe. So you've got a little that warming therapy happening when you hop into the hyperthermia or the radiation or the hyperbaric. Yeah. Holy cow, you're
optimizing.
Exactly. You're hitting a lot.
Optimizing synergies, which is really powerful.
Exactly.
So thank you for that. I'm so glad I was led to ask you that curiosity question, because I'm definitely changing my protocol. I'm going to add about 10 grams. So, and then the key too is obviously you want to be faster. You don't want to eat a bunch of fruit before you go into the chamber. Yeah. Because that's the sugars would definitely stop the production of ketones.
Totally.
As if you're watching this or listening, I'm sure you're intrigued and impressed with the depth of knowledge that Dr. Nasha has. And it's just, the important overall picture is that she has just touched on a fraction of the depth of her knowledge in this area. It is so, she briefly alluded to the testing that's done, but it's almost impossible to adequately treat someone unless you understand the testing and you integrate it and implement it on a regular basis. And she does a magnificent job of that. I neglected to mention earlier, one of the reasons I'm so impressed with her is that the mother of one of our veterinary doctors, who's on the site, Dr. Becker, came down with a problem. And I participated in the consults, when I just was beyond impressed with. I had no idea the scope and breadth of your knowledge and what you were doing. It was just, I was just shocked at how effective it was. Not effective, but how comprehensive. So, and effective too. But obviously initially you can only tell how comprehensive it is. So I encourage anyone to really, who's struggling with this, and I know many of you are, is to seek someone like her or someone she's trained that can help you with these similar strategies. So, I don't recall if there's links for that in the book. Obviously to the mistletoe, and you mentioned them, but how does one? Mistletoe is only one part of the intervention. It's an important part for sure, it's essential to almost all the therapies, but all the cancers. But how do you find the actual clinician? Is it the same people administering mistletoe will do the integrative oncology too?
Such a great question. And that's the one thing is just because you're trained in mistletoe does not mean that you're also trained in integrative oncology. Mm-hmm. And if you're an integrative oncology expert, that doesn't mean you've been trained in mistletoe. And so because of the demand we get on a regular basis and the inquiry we get on a regular basis from people from all over the world, January of 2020, I launched a metabolic approach to cancer sort of mastermind, bringing in the best of the best clinicians that I've known and worked with or consulted with on their patients' behalf that loved my approach and wanted to learn how to, not just be given a fish, but learn how to fish. Mm-hmm. And so brought in our first cohort of 12, and then our next cohort had 25, and then our next one had 28. And we're starting our fourth cohort tomorrow night with another 20 physicians from all over the world. We now have almost, I think, 10 or 12 standard of care oncologists who've gone through the program. The majority of the people going through my program are actually medical doctors from all over the world. The vast majority of them in the United States. But these folks are the folks that have been taught in a particular methodology that I've created over 30 years of my own experience of test, assess, address, don't guess. So they learn the why, they understand exactly the how of really testing and evaluating the patient and becoming truly personalized with that patient. They learn a ton about a lot of the off-label drugs and a lot of the other therapeutic interventions that are well vetted and pair well with standard of care or standalone. They learn mistletoe. They learn all about the terrain. We even talk a lot in our forums on even how to deal with the current pandemic, the current COVID crisis, because they're all in the same, they're in the same arena as far as we keep neglecting the terrain of the individual, and we keep looking at the wrong approach to treat or handle these crises, and we're getting further and further and further away from what needs to be done to change these outcomes. And these physicians are incredibly passionate. We'll have almost 100 of them trained by the end of the year, and all over the world. And our website, drnasha.com, has those graduates information.
Okay,
and those
that's the key.
Exactly.
I'm going to make sure that link is prominent, because the mistletoe is helpful.
Yeah.
And you may have someone locally who's pretty good, you're comfortable with. I'm not suggesting you have to see one of these 100.
Nope, not at all.
Many people don't have any clue how to find these.
Right.
And, so that's an issue. Now, just a personal question too, with respect to, many people go to Mexico, and you're going to be close to Mexico. I think you're even moving to Mexico.
Yeah.
So what do you think the best clinic in Mexico is? I actually went to the clinic called Sonavive, not for cancer treatment, just overall for tune-up, and was impressed with their therapy. And I wonder where you would rank them, and are there better ones than Sonavive?
Well, it's great because I know a lot of for just a little context, my brother-in-law was diagnosed with terminal pancreatic cancer when he was 35 years old, and he passed away in 2004 after a 24-year stage 4 pancreatic terminal.
Wow, that's pretty darn good.
Right? Exactly. So when he finally died of the disease, he had 24 bonus years, for crying out loud.
Probably from some of the interventions, I would imagine.
100%. And his interventions were.
They don't die. People don't die. People understand. People typically do not die from cancer. They die from the treatment.
Right. And he never did any standard of care. None. Yeah. They got in there with surgery, opened up and went, oh my God, it's everywhere, closed him back up and said, go home and get your affairs in order. My husband always tells a story. They told him to go home and get his affairs in order. He gave them the finger and took off south of the border. And lo and behold, 24 years later, he finally succumbed of the disease, but he didn't get actively sick. He had a quote unquote progression, because it never was in remission, a progression in December of 2003 and was gone in March of 2004. This was not like he was suffering for 24 years. This was him thriving, living, getting his work in the Smithsonian as a famous soil scientist, finding a marrying love of his life, raising 3 beautiful boys, watching like all the things. He lived a very beautiful life with cancer. That's the key we're always trying to.
Beautiful.
And so in that, I started studying, I started going and exploring all these clinics down in Mexico. And there are so many beautiful human beings in some of these clinics that run these clinics. But for me, when I'm a metabolic filter and I love the testing, and I like to bring in the best of both worlds of modern application with ancient application, I think the clinic that probably is doing it best right now, because they have somebody like Dr. Paul Anderson on their board, who's very, very up to date in his studies on vetted integrative therapies, but also metabolic therapies, is Sonavive, to your point.
Oh, really? So you're enforcing my impression.
I am. And I
didn't, we hadn't planned this. I had no idea. I was just curious.
And I don't want to be like, I don't want to diss others, but I like that they are, they're blending kind of the best of, they're moving forward. A lot of our cancer clinics in Mexico are doing the same things they've done for 40 or 50 years. And we've learned a lot since then. So we want to evolve and move with the time. And I think they've done a nice job of it. And I've gone there with patients, and I've gone there like you. They offer like a physician heal thyself little program and whatnot. And I do like what they're doing.
It's beautiful. I mean, it's an oceanfront apartment that you stay in property, and there's no EMFs. You can't have your cell phone there.
They don't wear your own clothes in there. They have you put on organic. And a lot of what I learned from them is we're applying to the hospital we're building in
it's
Arizona.
Pretty good. Yeah. I actually got my EMF consultant, Brian Hoyer, out there to help remediate them a little bit more. So, because they built cell phone towers, they didn't, but the community built them not too far from the property.
Love it. How cool. Good accidental side note there.
Yes. Sorry. So thanks. I don't want to overwhelm people with stuff, but the book again is Mistletoe, The Emerging Future of Integrative Oncology.
Nailed it.
All right. I remember.
It only took 4 times. We got it.
Yeah. Okay, good. So, and it's available real shortly. Just you can pre-order it if it's not available yet, and it should be to your house real soon. Certainly an important resource to integrate in any type of cancer therapy. So thank you for a number of things, for being a leader, an innovator, a pioneer, courageous, and establish and recognizing that people seeing you absolutely does not scale. The people who want to see you, you could live like 1,000 lifetimes and not see them all. So you had to reproduce yourself, and you've been doing that pretty effectively. And I thank you for making access to these approaches so available and continuing to improve. So you're a major resource out there, and I really appreciate you, and for writing the book, and more importantly, for providing a solution that conventional medicine just fails so miserably with.
Thank you. I'm really grateful for being here with you. Thank you.
Okay. Thanks so much for watching. Remember, hit the like and subscribe button so you can get more videos that can help you and your family take control of your health.